be a doctor. And there were lots of threads which were on the same vein, where students, and this was about a year back, so it's a little current, none of them are from India, but it seemed to me that students are now questioning the time that was spent on us trying to advocate or promote soft skills amongst students. So just hold that thought. So my talk today is not going to be about good communication or the positive aspects of AETCOM. We've heard from it from Avinash as well as from Dr. Manjari before. So I'm going to talk to you about the challenges in fostering good attitudes, mostly about good attitudes, a little bit about communication skills, and why we need to change this if we want to change what's happening at the moment. So I'll just be asking you to look a little bit closely at what can be done. So my talk is in 3 parts. Communications, not so much, but communications, attitudes, and action. So I put this slide because I love this word foster, because it means to promote growth, or it means to promote or encourage and develop. It's a lovely word, and that is what we are going to talk about today. And I'm going to start with communication. So I went through this paper, which is a discussion paper on by the National Academy of Medicine. It's a little oldish, but still it gives 7 basic principles of communication. The first is mutual respect, harmonized goals between the patient and the clinician, a very supportive environment for the communication to take part, appropriate decision partners. Sometimes patient is not in a position to take decision. Sometimes the clinician himself may need a dietitian or someone to give the necessary communication or information, the right information, transparency and full disclosure, and continuous learning. The patient learns from what the doctor has to say. The doctor learns from what the patient does or doesn't do at the end of it. So these are the 7 principles which were listed. And I'm just going to use the first 4 principles to say why we are not able to foster communication properly. Anyone would have come across this, where patients are yelling at doctors, doctors are shivering in their boots, or doctors are yelling at patients. These are very common in any government hospital or even in primary and secondary care, healthcare things. So the first question is, do doctors and patients respect each other? And the answer is no, we don't. In India, at the moment, we don't respect each other. And to add fuel to the fire, you have a lot of serials like this Dr. House, who actually goes around doing the worst possible things, and everybody claims that he's a very good diagnostician. I have Dr. R.P. Swaminathan. There is a whole, many years of students think he's the best diagnostician in medicine, and he doesn't go behaving like Dr. House. But we try to, say that, you can do whatever you like, but you have to be a good diagnostician. This is nonsense which is being propagated. So what happened? In medicine, like what we heard before, trust is the central pillar of the practice of medicine. And for trust to be there, we need to have transparency, we need integrity, we need fairness. Okay? Then only there will be trust. And the next question is, are doctors being held to a higher standards of integrity than other profession? The answer to this is yes, because patients need to trust us, because we are taking decisions regarding their health. And just like Dr. Reena said, not just health, but also on future, finances, so many things. So patients need to be able to trust us. Now, the contract medicine has with society is more of a social one. It is not a business contract. They don't expect, we were not expected like how you have a contract with an engineer or a plumber, where you come, you do some work and you are given money for that. That is not the kind of contract which is expected or what we have with society. It is a very implicit contract which we have. And therefore, when there is lack of integrity, there is lack of trust, and therefore it is leading to lack of respect. So there is no mutual respect between patients and doctors, and with so much in the social media, in our televisions, on the newspapers, you can see how this trust is undermined, and therefore we have lost respect. The second one is harmonized goals. So when a patient comes to a doctor in a hospital, these are his goals. I have to get well soon, get discharged fast, pay as little as possible if you are coming to a private hospital, and then go on with your life. But what are the doctor's roles, especially in a medical college? Keep the patient as long as you can, because for NMC we have to show that so many patients are there in your wards. Use for exam or teaching if possible. So if the patient has come, good. If his good hernia case means gone, he has to be there for the next 10 days. Get him to spend as much as possible, because we also have to show that we are making money, right? For example, all newborns are taken to NICU. Even if they have a perfect APGAR score, they are being taken to NICU, because NICU means money, okay? So there is, students are watching, and this is what came out in this morning also, where Avinash was saying, students are watching you behave, and therefore they are taking their cue from the way you behave, right? So in the OPD, what happens? Patient is coming, he says, I have taken leave to come here to be in the OPD today. I hope I can get good treatment. And the doctor comes and says, we have a meeting at 12 o'clock. Director has called for a meeting, clear the OPD. So what happens is there is no harmony between the goals between the doctor and the patient. So how do you foster something which patients, the students are not seeing happening day in and day out? That's the question. And if you see this cartoon, this is true. Most of the senior people say, I don't want to change, you change. I can make this blue-colored fellow standing up as NMC. Every 2 days we are getting different these things from NMC, and they say, we won't change. We'll keep on telling you what to do, you change, okay? So what happens actually is, after training in such settings, even if, supposing say on one day there are hardly any patients, let's say there is a bandh of some sort, and you have, your OPD has only 10 patients, doctors will still see patients in less than 2 minutes, because they are so trained to that. They can't adapt to conditions, even when conditions are conducive. So this is the harm which is done by our students seeing the faculty behaving in a certain way. The third principle, that of appropriate decision partners. So when you need people like a pharmacist to explain how to use an inhaler, or a dietitian, or a physiotherapist, these people are not there in primary and secondary care. They are there in some tertiary care hospitals, and some government hospitals don't have them too. So at times we don't get the kind of people who are supporting the patient. Patient may have dementia, patient may be very old, but they don't come along with somebody who cares enough to actually bring about a change in that patient. So appropriate decision partners also may or may not be available. Let's look at a supportive environment. Anyone who has been in an ICU, or anyone who has watched somebody being in an ICU, will know that this is the lousiest environment where somebody can take rest, okay? There's so much of noise. Now similarly, in an OPD, you need all this. You need quiet, privacy, enough time for questions and interactions, safe and conducive. Excellent example which Dr. Reena said, that she sent away the relatives outside to ask that patient who had fallen into the well, okay? Now, what happens in it is noisy, number of patients are surrounding and wanting to listen what is happening. So you do not have a conducive environment for communication. So in this situation, your barriers to communication also become your deterrents. Supposing language, India has so many languages. So sometimes you are sitting in an OPD, you will get a patient using a language which you don't understand. Or the patient may have physical some handicap, may not be able to speak, may not be able to hear what you are saying, and so on. There is also fear of litigation and of physical abuse. In many OPDs, some states, doctors are actually scared to sit in the OPD. And I know some things happen like this in the emergency quite often. There is a large burden of work which the clinicians have to put on, and therefore everything is quite hurried. Lack of knowledge, it is possible you don't know enough, or there might be unrealistic patient expectations. And of course, many of the, I wouldn't say older faculty, but many of the faculty lack formal training in communications. So therefore, these barriers to communication also become deterrents. So unless we address the deterrents and the students are seeing that they can be addressed, at least to some extent, then the students will know that it is worth us following this. So what do we do? For example, language. If you don't use technology, everything is on your phone now. You can easily translate, listen, and know what if somebody is speaking in another language. Similarly, if there is some hard of hearing, you can give them a hearing aid, or you take them, make your space soundproof, and so on. I have found making signs, large signs that somebody will be prosecuted, to be a good deterrent. So make signs to say that if you are abusive or if you behave in any wrong way towards doctors, you will be prosecuted or charged or something like that. And do an example once or twice, it works. At least it worked in Ames Bhubaneswar. I not had to do it anywhere else. If you are having a lot of work, delegate responsibility. Keep time to teach your students in the OPD. Don't let them see that you are rushed with your patients. And also, if you don't know about something, have the humility to say, I don't know. I have to find out myself. Can we all sit and learn about this together? Patient is having unrealistic expectations. We need to make it clear what the reality is. And then, of course, we can always learn and train ourselves. So if we address these deterrents, the students will see that it works. May not be 100%, but certainly good enough. And that itself will be, will help them or will foster them to do better, work better towards the principles of communication. Now I'm coming to the next part of my talk, and that's about attitudes. So what are attitudes? This is a slightly older paper, but it had some beautiful definitions which I like to use too. So attitudes, it is a psychological tendency that is expressed by evaluating a particular entity with some degree of favor or disfavor. So what we evaluate is with some degree of favor or disfavor, whether somebody has done good or not done good, or acted properly or improperly. So if we look at, so they are complex and they influence how individuals process information to motivate behavior. Now it has three components. It has a cognitive component, it has a behavioral component, and it has an affective component. So the affective component is obviously we are familiar with it, how it makes us feel, whatever it is, the object or person. The behavioral component is how we respond to something. It may be a verbal response or it may be a physical response. And there is a cognitive component, which is our perception and ideas and beliefs about the subjective matter. Now, the cognitive component actually affects the affective component, and this affective component makes us behave in a way which may be the proper way to respond or the wrong way to respond, okay? So there is this diagram. If you look at this diagram, right in the center, that dark green circle is the object of the attitude, and that could be a stimulus. The outermost circle is the observed response, how we respond to something. So it implies the attitude. And the circle which is just next to the inner circle is the attitude effect, which we may or may not infer, or we can observe. And the one after that is the internal influences. That means it may be habit, it may be perceived consequences, and so on. So I'll just give you an example. Supposing a patient needs blood, and the blood bank is refusing and saying, unless the patient